Hi, everyone. We're back. We're in our last and final session of the day. We'll be going till about 3:30 this afternoon. We have three wonderful speakers. I just want to remind everyone that the slide presentation that Dr. May gave us and any of the other links that were put on the in your chat room will also post in the conference room. So in the conference page rather of our site. So please keep watch for that over the next couple of days, and we'll try to keep those updated. I'll hand it over to Katti now to introduce our next three speakers. Katti?
Sure. Um, Good afternoon, Dan Mistak, Dr. Gibson, and Dr. Thomas. And we are doing this in alphabetical order. Dr. Brent Gibson is Chief Medical Officer for the National Commission on Correctional Healthcare, which is slated to have its spring conference in April in New Orleans. Dr. Gibson can talk more about whether that's happening, but it's a conference I've attended as a journalist. There are a bevy of ideas there. Dan Mistak is an attorney. He is director of the Healthcare Initiative for Justice-Involved Populations at Community-Oriented Correctional Health Services. As an attorney, he also litigates cases involving justice in correctional healthcare and other aspects of criminal justice reform. And then there's Dr. David Thomas, who is also an attorney. He is the former chair of the American Correctional Association Commission on Accreditation for Corrections and a former member of its board of governors. He is director of Nova Southeastern University's Correctional Medicine Fellowship. If I'm correct, that is the first fellowship of its kind in the country. Gentlemen, thank you for being here. We will begin with Dr. Gibson and go in alphabetical order.
Thanks very much, Katti. Nice to see you, and good to see you, Dr. Thomas. And it's a real pleasure to be here. And again, we appreciate the opportunity to talk about correctional healthcare and what we do here. Just a few minutes about the commission. We are the longstanding accrediting body specifically focused on correctional healthcare. And we were sort of born out of the attention on the topic of healthcare for those who are incarcerated after the Attica riots, which was early 1970s, if I have that right. And one of the concerns that the folks involved in the riot, if you will, it's maybe not the best way to describe it, but there was healthcare. Healthcare was not adequate. This was many, many years ago. And so really from that effort, we received some funding from the Department of Justice and wrote the original standards for correctional healthcare, which stay largely intact but updated up to this day. And as Katti mentioned, and I hope I'm not mispronouncing your name, I've known you many years and I go back and forth between, okay, good, give me the thumbs up, okay, good. We have really developed the world's largest education program for correctional healthcare. It's really the only, there are some other conferences worldwide that focus on corrections and mental health and other things, but we're really the only one focused on correctional healthcare. And we also publish a peer-reviewed journal. We have a magazine called Correct Care, which comes out several times a year, and a certification program. And just a small technical difference, a certification program is like what I might have as a physician as a credential, whereas an accreditation program is for a program or facility. And very recently, we've begun to respond to the needs of the jails and prisons around the country by providing a sort of consulting and commercial or sort of technical assistance services. So that's just a little bit about us. We are not an advocacy group, although we advocate, if you will, for high quality healthcare. And we don't necessarily take a position on various issues that you might hear, talked about in the media. We have a series of official position statements, which are available on our website. They're free of charge. They're updated frequently, and they kind of work hand in glove with the standards, the books, if you will, to help our constituencies provide a high level of care. We accredit about 500 facilities nationwide, and we have several thousand certified folks, and that does not include any of the other programs we work with in a consultative capacity. We work at all levels of government, federal, state, and local, and from time to time with some international or work from overseas. So, Katti, those are just some initial thoughts to get us started. The only other thing I would say is that, with the pandemic, there's been a spotlight focused on healthcare and correctional environments, and there's been good attention and bad attention. And I think that, by definition, most correctional settings are congregate, meaning people live kind of close together, they live and work together. And so that poses some risk for any infectious disease. But that's been longstanding and is not unique to the pandemic conditions. I would also say that many correctional facilities are very well equipped, and we expect them to have, if you will, a plan to handle something like a pandemic or a weather emergency or a fire, that kind of thing. And so early on in the days of the pandemic, we had just some very, very important, we heard about many quick response and very smart thinking on the part of our jails and prisons to kind of protect the health of the inmates and the worker population, the correctional officer and others who are another important group to think about, because those are the folks that come in and out of the institutions every day. But let me just pause there. I could just keep talking for hours about what we do, but I that's where I'll pause.
Sure. I want to ask you a question before we go to Dan Mistak. So what has been, or to what extent have your surveyors been in and out of facilities at this juncture, and what requests amid COVID have been made of the commission?
That's a really, really great question. Thank you so much for asking it. So we rapidly pivoted to doing a lot of our work virtually. And when I say virtually doesn't mean like you do it light, you do the same work, but you do it in an innovative way. And so our safety and health of our surveyors is really paramount. Without our folks in the field, we can't do anything, staff included. Most of our work is done, of course, by our associates out in the field. But we were able to pretty quickly pivot to a virtual option. There are some of our customers, if you will, our clients who really want some in-person presence. And so what we do there is a very careful risk assessment that's situation-based, because we really are essential workers. And from time to time, there have been some people who have been able to safely go out and do sort of whatever is a safe and healthy way to do a survey. They've been able to do that for us. And that includes me as a staff. I will also get out in the field in many cases. We would never ask anyone to do anything that I'm not comfortable myself doing. And the situation is very dynamic. Right now, we're in I'm an occupational medicine physician by training, but because of that, I get a good dose of public health and infectious disease. Not anything like an infectious disease specialist, but I kind of understand how the diseases move in the population. And so these things change frequently week to week, and we always have to assess where we are to be sure we're doing things safely. And also setting a good example for the people we go and see in the field, because a lot of what we do is preventive medicine, which is really what you hear, whether it's a mask, social distancing, or a vaccine. That's all preventive medicine, and that's the way we kind of prefer to operate. I hope that answers your question.
It does, and when we get to the Q&A, I want to come back and talk to you about adaptations and training and that kind of thing. Dan Mistak, thank you. Good to see you. You're on.
Great to see you, Katti. It's always a pleasure. So thank you for this invitation. I made a PowerPoint. I may have overdone it. Oh, and you know what? I can't even share. So I'm not even going to bother trying to get into that. So I will just talk freeform if that works for everyone.
That's fine.
Perfect. So my name is Dan Mistak, and I am the Director of Healthcare Initiatives for Justice-Involved Individuals at COACHES, Community-Oriented Correctional Health Services. We're a nonprofit that was founded in 2005 to try and create a better system of care for folks who are coming in and out of the jails. The way we see it is that sometimes people get care in the community, and sometimes people are getting care inside the jail. And so why in the world would we have different standards for depending on where people are receiving their care? So what we do is we try and provide technical assistance to improve healthcare delivery, to help communicate between community providers and folks who are inside the jail. And we also work on developing policies. So we've been really working hard about some policies that we will be talking about very quickly by the end of this little spiel here. in order to try and improve these connections between the community and the jail, and to really try and create a more rational system and not create these separate pathways for people who are justice involved. And then we convene stakeholders. We bring people from the corrections side of the world and also from the healthcare side of the world, which may not surprise you, are two parts of the world that don't communicate that often, even though folks who are involved with the justice system have incredible health needs that often go unmet. So the way I have been looking at what's going on is that COVID-19 is merely a pandemic that is sitting on top of an epidemic that already is out and going through our country. And that epidemic is mass incarceration and the way that policing engages with the lives of Black and brown people and poor people in this country. And it shouldn't be surprising. I hope it's not surprising to any of you that that COVID-19 is hitting the same populations that the criminal justice system has been hitting hardest. So there's an incredible amount of overlap, and the ways in which the injustices are compounding for folks who are justice involved and for people who are poor and Black and brown is just being exacerbated by what's going on right now. I just wanted to give the numbers for today. So from the UCLA correctional database, where they've been tracking the number of folks who have COVID-19 inside their facilities, correctional officers and the people who are behind the bars. You know, one of the things that we try and point out is that this is a huge risk for everyone, regardless of whether you're a correctional officer or if you're someone who's arrested. Jails are not a good place to try and keep track, to tamp down a pandemic. So according to their database, 196,127 incarcerated people have had COVID-19, 42,805 correctional officers have been diagnosed, and almost 1,500 people have basically received a death sentence while they're incarcerated from COVID-19. But this data that we have is coming with really significant data and reporting limitations. And I think this is one of the main policies that I'm going to hit on, or one of the ones that I think are changing and need to continue to be changed in the wake of COVID-19, is that each of these jails is a kingdom unto itself that's often run by a locally elected official who is deciding what sorts of information they want to get out, and what sorts of information gets out is often really also related to whatever the local political environment is. So there's not a lot of incentives to report out if you're a local jail that you're having a really terrible time, unless you might think that reporting that out might get you more help. or might help you be able to tackle the disease. Jails are not the kind of place that I describe the jails as being a cruise ship with poor sanitation, where you have people coming back and forth to the cruise ship every single day, bringing and taking with them the disease back to their communities. So we all know the not Disaster Princess, the Diamond Princess cruise ship ended up just having COVID spread through it like wildfire, and we've seen something similar happen in correctional institutions all across the country. But besides that, access to testing is limited. The justice system is often folks who are focused on last, and when we're doing planning for things like this around COVID response. Also want to point out that a large number of people are being released en masse by judicial decree or driven by local decision making. You know, sheriffs have the rights in many jurisdictions to be able to release people. And we are seeing that jails are trying to rise to the challenge. Prisons are not releasing as many people as jails are. But some of the disconnects that happen is once we have a judicial decree that releases people, it leaves community providers scrambling to try and actually meet the outflow of folks who are coming out. And at the same time, there isn't a whole lot of work necessarily being done to stop the inflow, because our justice system isn't one system. It's a bunch of systems patchworked together with people trying to make sense of what's going on in all of the margins. So we have police and probation who might be revoking people or sending people back into these facilities at the same time that sheriffs and the judiciary is trying to figure out how can people be released and be sent out, while at the same time reentry providers are facing incredible fiscal challenges because they they're trying to figure out how they do the services they do, and they provide congregate living facilities. So they're trying to figure out, how do we protect our staff? How do we protect the people who are coming in? And it just becomes a real recipe for challenges. the data that we know from before COVID-19 hit, Coaches always does this who's in jail little spiel. And what we show is that it's the poor, it's people who are from racial and ethnic minorities, it's people who are incredibly sick. They have higher rates of high blood pressure, tuberculosis, hepatitis, HIV, AIDS than the general population. They have substance use disorder and mental health conditions that far outpace that in the community. People who have history of mental health problems are much more likely to end up inside jails. And what we're starting to see, who's still in jail, so out of LA, and I have, you can reach out to me, and maybe Katti, I can send you the PowerPoint too if people want
That was
this.
wonderful.
Perfect. So
are you sure you don't want to screen share?
You know, I don't know if I can, and I can't while other participant is sharing. So someone else is sharing, and that's fine. So the disparities of folks who are still in jail are growing, actually. So in Los Angeles County, they're showing that originally Black men made up 29% of the jail population pre-COVID. After their mass releases, it now makes up 31%. Of the jail population. That same article talks about how the people with mental health needs are remaining behind bars. And here, where I live in my local jurisdiction, and I don't want to put them on blast because I've been really blessed to be able to see more closely what's happening here. The people who are going through competency hearing, or the people who are waiting to see whether or not they're fit to stand trial, they weren't able to be released when the Supreme Court did their mass releases because they were pending the disposition of their competency to fit trial. So we have people who we are still trying to figure out whether or not they're competent to be fit to sit trial, are being held longer because of their mental health conditions. So the people being left in jail are racial and ethnic minorities and people who are still incredibly sick. So there's major policy issues that are still sitting on the table. Also finding that transparency issues remain. Even though we have been gathering data and trying to collect it together, Marshall Project's been doing a great job of trying to get it together. This UCLA law program has been trying to get data, but all of this depends on people reporting out. The federal government, federal legislators, Elizabeth Warren, Senator Warren has created the COVID-19 in Corrections Data Transparency Act, trying to get bipartisan support for that and sign on for that in order to try and just get all of these federal facilities to report out what's going on and what their numbers are, their testing data, its impact on Black and brown populations inside these facilities, and then its connections to the communities. They only have jurisdiction over the federal incarceration points of contact. They really can't get access to the jail data. So having the correctional system the way it is, which is this incredibly, I call it hyper-federalized system where each sheriff is really in charge of their own domain, means that the data can be really challenging, even with sort of a federal legislative approach. I want to once again just remind everyone that jails are a place where people seek care or get care, regardless of whether we like it or not. They receive care inside these facilities, and we're really grateful for the NCCHCs and the ACAs that come in and try and make sure that high quality care is a part of this. But these NCCHC and ACA, we would love it if more jurisdictions took up those opportunities to receive that accreditation. Many still don't. And so what does it mean to have this sort of this system? How did we get to this place where there is a system where jails are kind of outside the broader healthcare system, and where are the policy opportunities to try and make sure that this that these gaps are resolved? Well, the way that we at Coaches see this, because we're kind of Medicaid nerds among all of the other kinds of nerds that we are, we look at the Medicaid system as being one that really can solve this issue. But inside of Medicaid and the Social Security Act, there was something called the Medicaid inmate exclusion. What this means is that anybody who is receiving Medicaid out in the world, if they're arrested and taken to a jail, they're no longer allowed to receive Medicaid services at all, unless they are taken into a 24-hour inpatient hospitalization. So we've created two tracks of treatment for people who are Medicaid eligible to beneficiaries. But if you're receiving care inside of a jail, you are no longer a part of the broader healthcare system And we know just from healthcare policy that once you start having separate payers for all these different providers, and the providers are not incentivized to communicate with one another, that we really can have some poor outcomes. It doesn't meet what's called the triple aim, which is the standard for healthcare policy, which means that we have individual healthcare improvements, but we also look at it from a population point of view. What are the ways in which the systems are created to improve healthcare for populations? And without the inmate exclusion really causes huge challenges with being able to create that system that meets people where they are. In the midst of COVID, this is, I think, one of the biggest leaps forward in policy, at least policy interest, something called the Medicaid Reentry Act, which was a bipartisan bill. It had Republican and Democrat support in the House. Would allow for Medicaid services to be available 30 days before release. This, for me, is, I think, one of the biggest things to watch. Are we going to move towards a health system where Medicaid can provide services behind the walls of the jail, or are we going to continue down this system where people don't communicate inside and outside the jail, and there's two systems that are created? So Medicaid Reentry Act would allow for community providers to reach in, really start providing the reentry supports that are necessary, helping get people enrolled in Medicaid in their local jurisdiction, even start helping care coordinators be able to connect people with SNAP and housing services. Where I live, housing support is a Medicaid benefit. So they could really start trying to get people connected with housing where they're going to go back to, which I think would be an incredible boon to folks who are leaving the justice system. So this would not only be able to help this current pandemic, it would be able to help the epidemic of the opioid use disorder epidemic that exists outside right now in the world. And this has bipartisan support in the House. The question has always been what happens in the Senate. This passed in the HEROES Act that was passed in May. When they went back at the bite of the apple in September for the HEROES Act 2.0, it passed that as well. And the question is just in Senate leadership, who's going to take up, and what does the Senate look like in the future? These are all the big questions that's out there. So, oh, go ahead. Sorry, I wanted to.
No, that was perfect. I was going to say the share screen function has been released and open to you. Do you want to whirlwind through that at all? Do you need any aspects of that?
I don't want to make anyone suffer, but let me pull up this this PowerPoint here just for the the final slide here. That is the what needs to change. Okay, so this is about where is policy going. These are, I think, some of the more policy things that have been revealed by this that we can kind of look into and look towards the future. Inside the health policy world, transparency is still lacking. We need to improve transparencies. Jails are still holding the sickest and the poorest folks. That's something we really need to figure out how we tackle. And then we need structural changes that reflect the reality of service delivery across multiple sites. That includes inside the jail, people going into the community and back and forth. People are in jails for less than 25 days on average. So how do we make sure that this revolving door isn't one that is exacerbated by healthcare discontinuities? And we need real collaboration for people who are leaving the jail. That means social service providers. It means just everyone who touches the lives and that we could really help out. But also correctional policies need to change. We're really seeing the challenges of having correctional policy being an emergent phenomenon rather than being sort of actually thought through. Often I think that correctional policy ends up being the negative space that's left behind of, what's the low-hanging fruit that all these different agencies can try and have an impact on, and then whatever's left over, we make the criminal justice system handle. And what happens is inflow and outflow become a problem. So we have people still coming in the jail as people on the outside are trying to release people because these aren't the same decision makers. Medical isolation, we're seeing that become a synonym for solitary confinement. That's a huge problem. It's not great for mental health. It's not great for the people who are in that situation. And it's not great for the people who are trying to provide help for people as they're incarcerated. And also a lot of places are having a hard time following CDC guidelines on distancing, hand washing, soap, all of that. That's a lot of correctional policy decision making. And I cannot stress enough that social policy needs to change too. Leaving jail, we have had people in my jurisdiction where I live be released still at 2 a.m. Their place that they're being released to is being written down as the congregate living facility for homelessness here, where there is an actual space for them to go, where they're not ready to actually receive people who are coming out. And they're just doing that to get people out of the facility because there isn't a uniform approach. So just because folks are leaving jail doesn't mean they're leaving with Medicaid, especially as people aren't able to come in and do enrollment right now. They aren't leaving with their Social Security benefits on. They aren't leaving with SNAP. They aren't leaving connected to housing. And we're expecting people to be able to not sleep in parks, to not be on the streets if they don't have a place to go. It's cruel, and it's something that we really need to focus on and address at a societal level. Otherwise, the pandemic's not going to get under control, and we're going to continue to keep just insurmountable challenges on some of the most vulnerable people. And so that's it. You only had to deal with one slide, and the rest of it was just me ranting. So thank you all for listening, and looking forward to Q&A.
Dan, thank you so much. And forgive me, all of these years I've been mispronouncing your last name. It's Mistak, right?
It's okay. People can say mistake, mistake. It works for me.
All right. Thank you. Dr. Thomas, you're on.
Thank you very much, Katti. First of all, I need to say hello to Brent. I haven't seen him in a while. And I also need to highlight Emily Wang and John May, who is still on the call, for the wonderful job they did just a few hours ago. In fact, John mentioned some of the things I was going to mention too. Dan brings up some interesting points. And first of all, when I ran the Florida Department of Corrections healthcare system, there's no point in constantly looking to the federal government. The federal government takes the position that states and counties and cities are responsible for their incarcerated people, and therefore Medicaid should not offset that responsibility. What we did in Florida was have a cooperative arrangement. Unfortunately, it fell apart when I left, with the Department of Health, that the inmates could apply for and receive Medicaid on the day that they left prison. So that instead of getting out of prison and then waiting for 30 or 60 days for their paperwork to go through, they could start their paperwork in prison, and they would not act on it. They would act on it, but not implement it until the day they left prison. And in doing that, most of our inmates who were Medicaid eligible, and unfortunately in Florida, not a lot of young Black males are Medicaid eligible, but those that were had their Medicaid start immediately upon release. And that was just a cooperative arrangement between our health department and the Florida Department of Corrections when I was there. Secondly, to speak to some other issues, yes, both Brent and Dan were correct in the Warp Speed initiative and the CDC panel that decides who gets COVID-19 vaccination when it becomes available. Prisoners were not even mentioned initially. From the work of some advocacy groups, NCCHC, ACA, the American College of Correctional Physicians, and Charles Lee in particular, and the American Medical Association, at least incarcerated people are now being considered and are on the list for receiving COVID-19 vaccination, which is a huge change from them not even being on the list previously. Now that begs the question is, will they take it? As Dr. May pointed out in the last session, inmates don't frequently avail themselves of current vaccines that are available, and there needs to be techniques developed to help them get over the paranoia of vaccination. And they have good reasons to be paranoid, but, and you could do that by having your correctional staff and your medical staff taking their vaccines in front of the inmates. to demonstrate that this is a positive thing to do. What I have seen, and I think we've sort of varied from our topic considerably. So to get back to that, what I have seen is an aggressiveness on the part of the organizations, the NCCHC, the ACA, the federal government, the American College of Correctional Physicians, those organizations that are involved with corrections advocate strongly for, have webinars and other intersections and other intergroups to create policy and procedure manual changes for correctional facilities. I haven't seen many of them adopted. Every facility that's ACA or NCCHC accredited has an infectious disease protocol, but it is not a pandemic protocol. And we need to step up and have pandemic protocols. The other thing that we need is to understand there can be unique ways to comply with social distancing and other techniques to avoid the spread of infectious diseases. We do not, as Dan pointed out, do a good job at hand washing, but it's simple enough that we could. You know, most facilities could get involved in that. You have to oblige your inmates to hand wash 4 or 5 or 6 times a day. And that could be done. The long-term solution, and unfortunately it's a decade to a decade and a half away, is the architectural rendering of facilities that can allow for medical isolation. But that's a long-term away, if it's even possible, because most of the prisons that I was associated with, the 55 major institutions in Florida, were dormitory-style buildings, and they were $33 to $50 million per construction. When you start talking about having medical isolation wings and things like that, your costs escalate tremendously. So there is a long-term solution, but whether we can actually arrive at it, I can't tell you. The other thing Katti mentioned in my introduction, we actually started the second, but the first successful correctional medical fellowship at Southeastern University, where I was professor and chairman of surgery, but also professor and chairman of a correctional medical department division. And we still have that fellowship running. There are 2 fellows in it, and this is a 2-year program to train physicians to the unique problems and the unique environment of corrections, as well as some of the unique medical problems that you're faced with in corrections. And with that, unless somebody has something specific, would turn it over to Katti again.
Thank you. That's wonderful. I want to kick off the questions and then open it up to journalists. And Brent, my first question is to you, and it's sort of a 2-parter. What percentage of correctional facilities, and to you as well, I guess, Dr. Thomas, what percentage of correctional facilities are accredited? And in this, if you can take a stab at that, and in this COVID moment, what are y'all learning about how you need to change your own standards of accreditation to fit a pandemic, the next pandemic, the things that you're learning about healthcare in corrections amid this?
Hey, do you want to start, or I can? It's up to you.
Go ahead, Brent.
Okay. I wanted to give you a break. But no, Dave Thomas is one of the greats of correctional medicine, and he was a kind host back, I don't know how many years it's been, 4 or 5 now, back in visiting the wonderful facilities at the Southeastern. A little nicer than Chicago, where we are now, for the record. He picked the better place to live. So the question, Katti, I wish I can speak only for NCCHC, and I can tell you it's somewhere between It's really less than 10%. And we accredit separately jails, prisons, juvenile detention facilities, and we have a mental health accreditation, and we also have an accreditation that enables facilities to acquire methadone for treatment of opioid use disorder. They're all separate programs. Jails and prisons are by far the biggest. So, to go back to something Dan said, which I think was just so on point, and again, Coaches is one of those great organizations that's been out there doing some incredible work. And I remember meeting many times in Union Station back when you guys used to hold meetings there, if you still do. But that's how I know I'm getting old in the field, is that I'm like remembering things from, a long time ago. To me, this is still a new and exciting job. But I can speak to 3 systems they're not really systems. I would maybe use ecosystems, and one of them would be the I'm an occupational medicine physician, so I can speak to the kind of workers' comp system. I can speak a little bit to the correctional healthcare system, and then to the broader US system. And as kind of true to our country and how we do things, and Dave alluded to this also with the deferral down to state, local levels, which is how we kind of operate. We don't really have a healthcare system. We have a lot of systems working sometimes together, sometimes not, competing with each other. It kind of drives up quality in some ways, but it leads to challenges like the pandemic response was arguably slowed nationwide because we have such lean operating hospitals. They can't ramp up to handle an emergency. It's very different than the military system where I cut my teeth, where you're designed to kind of hop on a dime to a big response. Okay, so that's kind of one thing. But to answer Dan's question, my opinion, why are there different systems? It really comes down to funding and resources. And the correctional healthcare system and historically the workers' comp system operate outside of federal reimbursement. And so that means you have to come up with some other way of determining quality and reimbursement. And so we would love every place we agree the inmate exclusion, it's almost like an afterthought in the law, but in my opinion, it rings as a punitive measure. Well, you don't deserve healthcare because you're incarcerated. And it's very anachronistic in 2020. And what little advocacy we can do as a 501c3 is focused these days on that exclusion. Because what that would do then is it would open up the door to being payment from the federal government. And we're talking about people that would have benefits otherwise, especially in the expansion era, that just simply don't because they're incarcerated. And what really just seems egregious is that includes people in jails who have not been found guilty of anything. So again, we're not an advocacy group, but that's just kind of illogical and counterintuitive if you ask me. So as soon as the federal government starts paying for things, it absolutely begins to take ownership of the quality and normalizes things. That's kind of how the VA operates, if you will. That can be good and bad. When you sort of, remove the, competitiveness and the innovation, you end up with like one system, and if it's a good system, great. If it's not, well, you can't really fix it. So anyway, those are just some thoughts that I think answer some of your questions. But Katti, since I talked longer than I intended, let me make sure I addressed all of your questions.
Fine. But how is COVID informing how y'all look at what the standards should be?
So I think that's great. Our standards are designed to kind of operate in a pandemic environment. We didn't have to do any kind of revisions or anything. Operationally, we had the challenges to deal with that I addressed earlier, but we have a standard specifically that addresses emergency response, emergency care. We have one that addresses infectious disease. We have one that addresses health training for officers. And those are really, they're designed to handle this kind of thing. So for example, we might do a survey and look for a mass disaster drill. That could be a tornado. It could be an outbreak of, SARS before there was COVID, that kind of thing. And so to be fully accredited, you have to have been able to handle something like COVID. But again, I will tell you that the sort of the variable that's harder to manage is the workforce, because our standards in general apply to inmates, their healthcare and so forth. We don't get into occupational health standards per se. And that's where Dave mentioned Charles Lee. He was working with a group that is focused very much on health and welfare for correctional officers, which is, it's the same problem when you go to work every day in a jail. I mean, this is the same occupational group. It would be like kind of in a grocery store, ensuring that everyone that walks in is screened, but you don't even look at the staff, even though everyone's intermingling with the produce and everything else, if that makes sense.
Sure. David, you want to weigh in?
Yes, ma'am. I'm a little embarrassed. I should know exactly what percentage of facilities are accredited by ACA, but I did not. That's not a figure that I looked up before the conference, and so I'm sorry I don't. I would say the minority of them. It is voluntary. Many states that have been involved in litigation, the upshot of the litigation is that federal judges are requiring either NCCHC and more frequently ACA accreditation for their facilities to get out of the lawsuits. So that has been significant in bringing up the standards and the care in many of the state run prison systems. Like Brent mentioned, the accreditation system indirectly addresses pandemic. It doesn't mention pandemic at all, but it does mention mass casualty events. I did not foresee, and I don't know that anybody except a handful of people who retrospectively said they foresaw the impact of a single organism pandemic. And so even those facilities that were accredited had major problems with them. Now, we are somewhat fortunate. The USS Roosevelt event showed us that if you don't do anything, but you live in close quarters of 5,800 young men and women who are healthy, they have to have physical exams to get into the Navy. About 1,200 of them are going to come down with COVID and one die. The incarcerated numbers that I have, and I only have them for Florida, show a little bit higher than 1 in 5, maybe closer to 1 in 4 people getting infected, but not everybody infected. And the 1,500 deaths that Dan talked about is probably not as high as if we were to look at every single death. However, remember that's out of 2.5 million incarcerated people, 2.8 million incarcerated people. So statistically, it is not as rampant as the media has portrayed it to be, but it is a significant event. And even if the death rate, which as more and more cases are discovered, your death rate is going to get smaller because your denominator gets so much larger. Even if the death rate erupts out at 0.8 or 1%, which is where, in my mind, I think it's going to be, of 6 billion people, 1% is still a large number of people. But statistically, it's not wild. And we do need to step up and address it better than we have. And I know our standards committee is working on addressing and using the word pandemic in some of the newer standards, which we really haven't done before. We've talked about epidemics, but not pandemics.
Thank you. Michael Gelb, if you take the questions.
Yeah, thank you, Katti. So the first question is from Tom McMorrow, who's an independent journalist. This question is for Dr. Gibson. So Dr. Gibson mentioned that there are some correctional facilities that had actually planned in advance for the possibility of a pandemic. I would like to hear about 1 or 2 of those and how effective were those advanced plans. Also, how common was it for correctional facilities to have advanced plans for a pandemic?
Thanks for the question. Let me think. Of course, I can't name specific facilities because of confidentiality and so forth, but I think an initial comment would be, if you do the best job in the world at preventing the pandemic in your area, and sometime in the future, one person comes through with the disease and it blows up on the inside, that's kind of what happens. And why I say that is, I might have seen facilities that did an incredible planning job. They might still have a problem now with COVID. In other words, the test is not, and this is kind of a broader statement on infectious disease. It's pretty tough to stamp these things out, any of them. And so I would say that what we saw, especially early, was a proactive attempt, if you will, to keep the disease out of the correctional environment. And in many cases, facilities we saw stayed COVID-free. They're sort of little islands of purity, if you will, among a raging sea of COVID. And I saw this in more than one occasion. I just can't give you specific facility names because it wouldn't be appropriate. But the things that were done early on in jails and prisons that were not really done, broadly speaking, would include the use of masks, of course, staff and inmates, screening at the door, quarantining, medical isolation. I totally agree with Dan. There's like this word, musical chairs, that goes around with isolation and medical isolation versus admin versus, totally get it. Medical isolation, as we define it, is very specific and narrow and for a particular reason, not because of anything else. But this is one of those cases when medical isolation was entirely appropriate in many, in many cases, and the same way you'd get in a hospital, for example. So if you probably do a little Google searching around, you might be able to find some success stories regarding the early management of COVID. But we'll just, I guess we'll just leave it there. But yeah, so does that answer the question?
Yes. I think the journalist will get back to you if it doesn't. Michael?
Yeah, our next question is from Grayson Dangor. Sorry if I'm mispronouncing that. Grayson is a contributor at Forbes, and Grayson would like to know, I've heard of people not being enrolled in Medicaid after getting released from Rikers Island. Are there any consequences for the institutions that are not enrolling people in Medicaid? And would the Medicaid Reentry Act fix this issue?
Dan, I was going to ask you to take that. And also, would you paint the broad landscape of who's doing that kind of thing?
Okay, great. Yeah. So the answer is there's probably no repercussions for an institution not enrolling someone. So some places by statute have enrollment as a part of the reentry process, but there just doesn't seem to be teeth in a lot of these. It's really vague who's supposed to be doing the enrollment, when it's supposed to be done. So there isn't any incentive really to enroll people, except that maybe that individual, if they aren't able to get the care that they need on the outside and they have SMI or substance abuse needs that aren't being met, then they'll be back in your front door again on the other side. I doubt that there's really any repercussions for that. But across the board, what happens is a lot of jurisdictions are tackling this enrollment in a lot of different ways. Some are in Chicago, for example, Cook County Detention Center is partnering with TASC, and TASC is doing a great job of enrolling folks before.
What is TASC? Would you spell it? I know TASC, but would you give the acronym?
Yeah, TASC. I don't know what it stands for. I'm sorry. You can't put me on the spot like that. I barely know my own acronym for coaches.
I'll get it. I know them. I'll get it.
Now I'm going to have a part of my brain trying to process what that is.
No, don't worry. I'm sorry.
That's all right. No, don't worry. But TASC is in Chicago. They're doing a great job. They also work on diversion opportunities, things like that. So check them out anyways. But here's the problem. So, usually it's folks coming in from the community into these facilities to enroll folks. This is at a time when we're trying to keep people out of these facilities, even people who are coming in normally and trying to provide services. So where I live, it's been totally cut off that folks just can't get enrolled by outside enrollers coming in to do the navigator process. But some jails are actually trying to be at the forefront of this, and they're actually trying to do the enrollment process through their own staff as people leave, usually larger counties, of course. Besides that, the question is, would the Medicaid Reentry Act make a difference? I think so. I certainly think so. I mean, just from the financial point of view, you have the opportunity tap into this sort of federal opportunity to support people who are inside your institution, that's going to be, I think, a great, a real incentive to make sure that people get enrolled as soon as possible inside the Medicaid program so that they can avail themselves of that funding service. Because look, all of these local jurisdictions are going to be facing a fiscal cliff. The federal government is the only place that can deficit spend. States and local jurisdictions cannot. So it's going to be a huge fiscal relief for folks to be able to enroll folks in Medicaid as well. And then one other caveat, there's something also that's allowed called presumptive eligibility. Maryland is really trying to implement this and doing a good job of this to make sure that people who leave the institutions are deemed presumptively eligible for Medicaid. It's a much shorter form. It gets them in the process a lot sooner. Within 90 days, they have to fill out the long form and go through the entire process of enrolling in Medicaid. But it's a really good opportunity to get someone enrolled, maybe get them a case manager then who could then help them do the formal enrollment process later on. So that's something coaches always recommend across the board too.
Before we move to the next question, I just want to add to that. Amid COVID, what is the level, nature, difference, push into medical care discharge planning, both for people who have COVID, but also just for the general population? Are there any changes taking place there?
So I think this goes back to what Mr. Thomas was saying also about the numbers of people who are dying in jail. So so I want to make sure I connect to that point too. One is the discharge planning. Again, you know, where I live, they are supposed to make sure everyone has their ID when they leave. Everyone has all of the information that they need in order to enroll in a vast bevy of services. Even if they aren't being enrolled in them, they're supposed to be given the resources to be able to do that. They're also supposed to be enrolled in the Medicaid program. That has been completely suspended. Because they just can't handle the outflow. They get a Supreme Court order that says you have to really give us a list of people who have to be released by this date. And suddenly you've got all these correctional staff who, by the way, are incredibly stressed right now and facing, they're facing PTSD and people quitting and people leaving pretty in pretty stark ways. And they just can't handle the enrollment. And then, of course, partnering with these outside agencies to come in who normally do these things, that becomes a challenge as well. So I wouldn't be surprised, and I don't have data on this, but from the anecdotes that I see, there's been a real drop off in the ability to be able to provide these connections that are necessary because of the volume that's just being pushed out all at once and the extra COVID precautions. At the same time, this connecting in with the deaths, I have heard cases of places in California where an individual tests positive, and because they don't want that positive inside their facility, they will push that person out as quickly as possible. Just release them in the community. Nothing else. No other supports like that. And I've heard reports of people dying at bus stops who were released from their facility because they weren't connected with other things. So I think that some of these numbers that, going back to the transparency, there's a lot of ways that people want to make sure that they can game the system. They don't want deaths inside their facility. So if they could get people out the door ASAP who might be looking like they have challenges, I wouldn't put it past some of these facilities to do it because there isn't a lot of oversight.
Are you in Alameda County? I'm sorry. Are you Alameda County? Where are you, Dan? What?
I'm in Hawaii.
Oh, you're still in Hawaii? I'm sorry.
Yeah, you think I'm going to leave in the middle of the pandemic? No way.
Sorry.
Right
I'm back in California.
Florida and Hawaii. Which one doesn't belong? Chicago.
I thought you were still in Hawaii. David, you wanted to add to that?
Yes, ma'am. To comment on the effectiveness of accreditation, to try and do that numerically becomes artificial, because I know for a fact many state prison systems stopped accepting inmates from jails for a while, and that makes the jails look terrible. And yet the prison system numerically looks better. And this is an inappropriate thing to do, but I don't know that there's any way to stop it. But that's why it's very difficult to numerically measure the effectiveness of accreditation. It can't be, it has to be measured in other ways.
Michael, thank you. Michael?
Yes, thank you. So the next question is from Aaron Morrison, who works for the Associated Press. Aaron asks, this month, voters in LA County, California, passed a measure requiring 10% of the county's budget to go to alternatives to incarceration and community investments such as affordable housing, healthcare, small business assistance, et cetera, et cetera. How might initiatives like LA's Measure J help with reducing the spread of COVID-19 in carceral settings? And do you have specific examples of programs or publicly funded agencies that already do this work?
One of the issues, as I see it, if I may, Katti, is those are fine unless or until your judicial system has faith in them. If they don't have faith in them, no police officer sends somebody to prison. They may send them to jail, but they don't send them to prison. And until your judges have faith in alternatives and that the alternatives work, you're not going to see wholesale adoption of things like that. And that's been my experience in some of the counties in Florida that have had some wonderful programs and some wonderful diversion programs, but it took 5 to 7 years for the sitting judges to buy into them.
Dave's exactly right. I'm just going to jump in uninvited, and sorry, Dan, please do the same. But this is about culture change and about there's all kinds of words that are laden with meaning that I'm probably not trying to imply. And again, as an organization, this is not we're here to be sure that whoever is incarcerated gets quality health care. And whether incarceration means X, Y, or Z is kind of a different question. There's always room for improvement in healthcare. But we do have a different attitude in our nation toward crime and punishment, the origin of, and I'm not an expert in law enforcement or penology or whatever, but it's like we have, growing up here in this country and my spouse is from another country, we just have our own way of looking at things. It's kind of like law, order, punishment. And if you mix into that the structural racism, discrimination, and all these other things that are very real, you have a problem. And so that has to be unwound from the ground up with a change of heart and a change of how people view other people, to be perfectly blunt. And that's a big ask, and it takes time, but we have to do it. So sometimes when we get, after people and upset about the levels of incarceration, we may be kind of targeting the wrong thing. It's easy to take a swipe at a sheriff or a DOC director. Most sheriffs are not into the correctional mission. That's like an afterthought. The jail is that thing out there. A sheriff is by definition a local law enforcement official, a local elected official in most counties. And to them, I think speaking for them, and I can't do that either properly, but it's a giant liability they'd probably like nothing to do with. And that's why you have regional jails and other things going on out there to kind of take that incarceration mission out of the local sheriff. So these are big issues that we have to wrestle with. And I think we can. And I think despite all of the problems of 2020, the list keeps growing, right? It's a great opportunity. To quote our former mayor, you don't let a good crisis go to waste. It's a great opportunity to rethink a whole lot of stuff to include the things we're talking about today, if you will. So again, long-winded answer, but Dave is exactly right. And, whether he states it directly or not, the judges are a part of the broader culture and often not particularly accessible to most of us. I wouldn't know the first thing, unless I happen to bump into one, how to have a communication with that level in the judiciary. So anyway.
If I could jump in too, just from the sort of healthcare policy nerd side of things too, historically, I'm going to bracket, and this is not responsible to bracket this, but the history of slavery and the way the penal system has engaged with that in this country is something that we are dealing with right now and we are talking about right now. And that's why the slides, which will be sent out to you, feature that data. But I just want to take this from 1963 on, where we had the move to deinstitutionalize in this country with the promise of building community supports for people on the other side. And we never invested in that. So that promise was never fulfilled. And in that same time, we saw the incarceration increasing over more and more each and every year since then. So you know, the first time that that coaches went to visit a sheriff, we were going in Massachusetts, and basically when we got in and started talking about the mental health problem, they said, yeah, what took you so long? We have known that we are the mental health institutions for folks. So we have a system that was promised to create community support. The funding for that never came through, and it really, really didn't actually start having the money from the federal government really being there until 2014, when the ACA passed and really kind of mandated inside of essential health benefits that behavioral health, mental health, substance use support be a part of our healthcare system, and that parity be a law that, you know, makes sure that healthcare, physical health and behavioral health are treated on par with one another. That's only 6 years ago. So the way I look at it is we have a field of dreams problem, which is that if you build it, they will come. Right. So we need to really start building out these programs in the community. And what that does is it creates these alternatives. And then the judges will be on board, and we'll have places to divert people, and fewer people will even engage with police to begin with, because they'll have already been able to receive support in the community all along the way. So we can't think about the correctional system as siloed, because people do pass in and out of that system, and they pass in and out of the health and behavioral health systems inside and outside. We have to start thinking about this as one system and thinking about what are the ways in which we alleviate the pressures that have been on the correctional system by creating more community support. And I think that there's an incredible amount of bipartisan support. One of the only things that there's bipartisan support on is the need to expand mental health for folks who have just not had access to it. So I think if we can focus on creating those alternatives naturally, in the same way that by ignoring those needs, sort of the carceral state has been able to expand. I think if we start focusing on those needs in the community, the carceral state's going to stop playing such a big role in the lives of people who are incredibly in need. So that's just my opinion too, and it's, you know, based on a weird materialist analysis too, which says, you know, the hearts and minds will follow once we get the stuff there. And proving its point and use.
Michael?
Yeah. So the next question is from Chandra Bozelko. Sorry if I'm saying that wrong. This question is for Mr. Mistak. Can you talk a little bit about the ways that Medicaid for prisoners would facilitate vaccine distribution? Or alternatively, how not covering prisoners with Medicaid will hinder vaccine.
Hi, Chandra. I love your article. Thank you. So, you know, I don't think that Medicaid actually, so inside the facility, right, what we actually need is the federal government to say, first of all, this vaccine is tested, it's proven, the FDA has, like, we are not doing a Tuskegee experiment and making sure that the people who are involved in the justice system are just getting this first so that we can see what the long-term consequences are, because we rush things through, right? We need to make sure that that's like first and foremost. But this is really a federal policy decision. It's a CDC decision, and Medicaid isn't going to necessarily it won't play a part of that, because this is all going to be funded basically through non-Medicaid systems. Now, what I do think that Medicaid could play an important role is that if folks have access to Medicaid, then they have the care coordination side of things, where they can have somebody checking in and say, hey, this is actually 2 shots, so you've got to come in for your second shot, and, you know, or we'll come to you for that second shot since you're out in the community. And you know, Medicaid can really pay for a lot of these care coordination side of things. So I think that maybe that's where Medicaid can play its role. But I think in terms of delivery and prioritizing folks in jails and prisons, I think that that's much more that we have to really rely on on kind of leaning on the CDC and like HHS and their delivery priorities. I hope that answers the question. Does that make sense?
I'll speak for people, and if it doesn't, they'll get back to you.
Okay.
So I wanted to ask this, if you would peel back a bit, this notion of medical isolation amid COVID versus solitary confinement, and are y'all seeing instances where the distinction is not great enough? And what does medical isolation look like?
Medical isolation in most of the facilities that I worked in Florida, or that I oversaw in Florida, is different than administrative or disciplinary confinement. It is in the medical facility itself. It has reverse airflows. The environment within the area looks quite similar. But you know, it's not plush by any means, but it is in the area of the institution defined as your medical unit. The problem with this disease is there's usually only a handful of, for want of a better term, cells that are isolation cells. And they have multiple roles. Although they have reverse airflow for infectious diseases, they also are hardened against suicide and things like that. And so in appearance, they don't look the same. In the activities that surround them, they are different. The problem with COVID is you ran out of those cells. And so they wound up having to be put in non-medical isolation cells, read administrative or disciplinary confinement cells.
How many, is there a sense of how many prisons or correctional facilities, jails and prisons have reverse airflow generally, not just in the medical isolation units? And how does that factor in this moment?
I don't know of any jail or prison that have a reverse airflow system not in the medical facility. I mean, it would be, in my mind, it would be inappropriate to have that on the general population.
Why is that?
Well, because they're expensive to build, and you generally don't have need for them. And I wouldn't want an officer to put somebody in a reverse isolation cell, not knowing what's going on or what he's doing. So I think those ought to be in the medical area. But that begs the question then, do we need more of them? Do we need more of them to sit around empty when there's no pandemic? This is the issue of the ventilators. My daughter takes care of, she is a physician in charge of an ICU, and was blisteringly angry that they didn't have enough ventilators. But, when you think about it, do you want 1,000 ventilators sitting somewhere idle waiting for the pandemic? Well, in the military, you can do that. But because, you're paying $100 for a hammer. But, in most of the world, you just can't do that. And all I can do, once again, is talk about the 55 major institutions that I was responsible for in Florida. All of them except one had at least one or two reverse airflow isolation cells.
Steve?
Yeah, Dr. Thomas, I wanted to pick up on one of the things that you said earlier that really intrigued me. You said that you felt the media had overstated, if that's the right word, a little bit of the impact of COVID-19 on correctional facilities. So I'm wondering if you could just pick up on that and say, well, what really does the media need to know, and what areas can reporters, especially those who are with us in the webinar, really concentrate and focus on to make a difference in public policy?
When I talk about, I have been asked to give several talks on COVID-19. When I talk about that, I will only quote from replicated peer-reviewed articles, because there's a couple of issues. The scientific community has not done us a favor, because there has been this push to be first in publishing an article about COVID-19. And then they have not even had the courtesy to retract it when it's been demonstrated that it's not necessarily correct. So the only valuable data is replicated peer-reviewed data. Many areas of the country were reporting positives from the antigen tests. The antigen tests are notoriously incorrect. You can have COVID-19 and a positive antigen test. You can have COVID-19 and a negative antigen test. You could have had COVID-19 and had a negative antigen test. They're all over the place. They're not accurate. The only accurate tests right now is a polymerase chain reaction, PCR test. And yet you see data being distributed widely, talking about the number of positives and the increase in positives. When I talk about this disease and talk about the media and approach to this disease, and this probably won't be popular in this discussion, I draw the analogy with Theranos. Theranos was a company where the CEO was on the and I know Forbes is represented by there, but on the cover of Forbes, wonderful, you know, this little box will do all these things. And several years later, it was wonderful, except it didn't work. And in my mind, we're seeing, and part of this is the fault of the medical scientists that are rushing to publication, things being quoted that are not accurate and in the long run won't help people. Now, I don't know, you ask me, you know, how do you address this? Well, science is pretty dull, and medicine is pretty dull. And dull doesn't generate media response. And so I don't know how to address it. But, you know, there are issues.
Dave, you're so right. I'm watching the questions here, and like the phenomenon you're describing is happening in our chat. So polymerase chain reaction is a scientific technique. It's not necessarily a test. And so we have the doctors in general are not, we've been given a lot of like airtime during the pandemic because it's a health problem, but we're not always the best at couching messages. It's not how we're trained, and it's not how we respond, and it's not lots of things. So I think part of the challenge right now, as Dave said, is it's this sort of, this is the first pandemic of the information age, not of the world. We've had pandemics for a long time. And so what we're seeing is lots of people having access to lots of information and lots of other people. And we're seeing that kind of, you know, Brownian motion of information, if you will. But anyway, so just wanted to stick that in there. But it's a key consideration that I think Dave is talking about. And that's why we have to be careful what we say, because it can easily turn into something else that was not what was intended.
So one of the journalists did ask the question, what is the name of the test, David, that you were saying is most accurate?
It's the technique to determine the segments of the virus, and it's called polymerase, Polymerase, okay. Chain, CHAIN, reaction. And it's a PCR predicated test.
Okay, so I have another question, but just to the journalist, I posted Retraction Watch, which is run by a physician. It's a great place to go to sort of see what science should be debunked, etc. Kelly, you had a question. Do you still want that in? And I'm not even sure if it got answered. She was asking about, and her question I think was to you, Dr. Gibson, but it can be to everyone, lawsuits that have been filed. Yeah,
I answered it in the chat with a case.
Yeah, okay.
That's so just a current one. That's the most recent one I have access to.
Oh, okay, I missed that. And I'm gonna put in the chat, one of our speakers, Dr. Carlos Franco Paredes, is an expert witness. He just was a witness in a lawsuit brought by the Southern Poverty Law Center. I'll put that in the chat for whomever asked that question. So my question is this, as we sort of wind down and y'all begin to think about stories in this area you think journalists ought to be covering, stories that journalists ought to be undoing that are not well-founded. And that is this, why just 10% of correctional facilities being accredited? Why is that?
Corrections accreditation is voluntary. It is not cheap. As you spend your money as a correctional administrator, do you want to include a voluntary program when you're confronted with other needs? Many states and many jails, many counties and cities do step up and do that, but it is not necessarily a high priority as you expend your budget. And, you know, many places feel their own quality improvement measures handle that. I don't personally agree with that, but, you know, I have seen accreditation, both NCCHC and ACA, truly improve correctional outcomes. But it's a voluntary program.
It
Except
becomes
following
less
litigation.
voluntary. Yeah, Dave is right. It becomes less voluntary when you attach dollars to it. The Joint Commission is a voluntary program, but guess what? You don't get paid. And there are others, but that's just an example. You don't get paid by the federal government unless you can demonstrate you have a standard of quality. And so that piece is missing in corrections for the most part.
It's not that it's not a philosophical resistance to be accredited, strictly money.
I would suspect that's correct.
I agree.
So thank each of you. I want to just do a whip around, starting with Dan, to discuss what stories you think we got to be covering on this front. What journalism you've seen that maybe lacks nuance, maybe needs a little correcting, that kind of thing.
Great, thank you. Yeah, so you know, one of the thing out there that I think is the hardest is that when we're talking about these mass releases and decarceration, and we talk about people going back inside the system, we're missing out the nuance of why they get back inside jail. The Lawyers for Equal Justice in Hawaii released a really interesting study called Outbreak, which they looked at why did people get reincarcerated and what really happened. They compared it to the journalism that was happening here in Hawaii and described the ways in which a lot of fear mongering had been used in order to kind of like just drum up sensationalized responses to the state's demand for decarceration. So I think contextualizing this problem as being that folks are released to a broken healthcare system and a broken social safety net system, and then they end up back in corrections. And that's I think a really interesting and unique way of describing and talking about this topic. So here in Hawaii, people are released. The reasons the vast majority of people who had their revocation happen was because they were sleeping in a park because they didn't have any other place to go. And then they end up back in jail. That seems like a big problem to me. And that's a lot different than the reporting which was coming out of our local organizations here, which said, they're decarcerating and 20% of people are going back, are reoffending. Well, what is that offense? It's quality of life offenses. So I think that's where some real nuance could be brought in. And I think that we could really start trying to break down these silos and show really we have some major needs out in the community and those needs are not being met. And that's why the justice system is taking such a central role here.
Do you see COVID and decarceration and alternatives to incarceration changing that dynamic in any way? And if so, how?
I hope so. You know, I think that this is the, at this moment where there is the demand justice for Black Lives Matter, where they're saying, what in the world, why are we spending so much money on these really fundamental health issues and paying for it through the justice system? How do we build sustainable and real things on the outside in order to support people where they are and in what they need? So I think that this is all a part of one big story. And I really hope that we can just center the needs of folks who are involved with these systems and really be able to talk about what they need and why they end up inside the justice system and how the justice system just derails their lives, the lives of their families, their communities, and that we have this unique opportunity to strengthen our healthcare system while at the same time improving public safety.
David?
Well, I hope Dan's right, but I suspect he's a bit of an idealist and an optimist. I believe that large societal movements like this become transient, and as a society as a whole, we have a short memory. And I feel that there will be targeted small changes, which are not media exciting, but are very, very meaningful. I wouldn't presume to tell a journalist how to do their job. All I've ever been is the recipient of that function.
And so what stories should we be covering right now? And I know you from other panels, so I know you have ideas. So what should we be covering on this front, the COVID front, the correctional healthcare front?
I can't answer that off the top of my head, Katti, and I really did not give it any thought.
Okay.
I think that there are positive responses that are being made. I think the fact that inmates were not even considered in getting a vaccine from the federal government panel, and now they are, is a major story. It's just not exciting. I mean, they weren't even on a radar, and now because of the actions of a few groups, they're at least being talked about and thought about. I haven't seen a single report of that in the media, and things like that. There are small incremental changes that are being made that I think ought to be more highlighted than these big exciting things which wind up not going anywhere.
Brent?
Thanks. I think everybody said it so well, and you've heard enough of me. I would just say that we need to rethink again. It's not so much pandemic oriented, but what it is that buys someone a ticket into jail. Is it quality of life? Is it mental health? Is it substance abuse? How can we work on rethinking what the purpose of incarceration is?
Thank you, gentlemen. Steve?
Yeah, so I want to thank everybody. This has been a really thoughtful panel. We could have gone another half hour, I think, exploring all the implications of COVID for corrections. But you gentlemen have certainly started us off, I hope, in the direction of getting more stories done. So we're ending a little bit early, 4 minutes early, but I'm sure no one will mind that. Please ask you to watch our conference page, where we'll be sending you information about, as well as some of the links that you've heard today. We'll have a video recording of today's session available and uploaded, I hope, within a few days, and I'll let you know about that. Other than that, if you have any specific questions, please let me or Katti know. You have our emails. We next meet as we look at the larger implications of COVID for other parts of the correctional and the justice system in 2 weeks. Next week is Thanksgiving, of course. I wish you all a safe and socially distanced Thanksgiving. Thank you again, and we will see you in 2 weeks.
Thank you,
Very
everybody.
much.
Thanks so much.